just to introduce myself, I'm Jenny Reindorp. I am Director of Development and Engagement at NHS Providers, and I'm really delighted to welcome you to this event focused on learning from provider collaboratives, on how to work effectively in integration at Neighbourhood and Place. Today's event is part of our provider collaboration programme for those of you who haven't joined us before. And what we're aiming to do is focus on how we can share good practice and peer learning on this range of hot topics that provider collaboratives are working on, really focusing on realising the benefits and sharing the learning from all that you've been doing through events like today and other webinars and resources. And as I'm sure you're all aware, in terms of our focus for today on neighbourhood health, it's a key government priority in terms of thinking about how we can develop more care at home and closer to home, and one of the three big shifts to improve people's access, experience and outcomes, and of course ensure the sustainability of health and social care delivery. And we'll all be looking forward to the 10-year plan, which we are expecting to include proposals on how to make this emerging vision a reality. So in today's event, we're going to be exploring how provider collabs are already supporting a more integrated local approach to health and care delivery through building partnerships at both place and neighbourhood level. And we're going to hear from two very different case studies. Thanks to the team, and thanks very much to the speakers I'm about to introduce for finding the time, because we've got a great example of an all-in collaborative in North Central London, and a very different acute collaborative in a rural setting. So hopefully we will try and see if we can pull out some of the really helpful actionable insights and the learning that you may take away to apply in your local context. So we're going to hear first from our North Central London colleagues in the North Central London Health Alliance. So we're joined by Kate Pett. Welcome, Kate, who is Managing Director there, and Sally Liddamore, Head of Camden Integrated Community Health Services. So welcome to you both. And then we're going to hear from our second case study down in Dorset. So we're joined by Nick Johnson, who is Joint Chief Strategy Transformation and Partnership Officer at Dorset Healthcare and Dorset County Hospitals NHS Foundation Trust. So welcome to you all. And there's going to be lots of chance for questions as we go. Do just pop any questions or comments in the chat, or I will just bring you in. And don't feel like you have to, we're going to share quite a few slides, but don't feel like you have to scribble away. We will circulate them in the post-event email. And those of you who are just joining us, welcome. Do feel free to introduce yourself in the chat. So I'm going to hand over straight away to Kate and Sally to get us going. So thanks very much, both of you.
Thanks, Jenny. As Sally said, we're both from North Central London, and what we're going to do over the sort of course of our 20 minutes is kind of take you from our provider collaborative, which is an all-in collaborative, and I'll describe how that's set up in a second. I'm going to take you through sort of showcasing two different approaches that we're currently taking in North Central London to neighbourhood working. The one I'm going to present, which is around starting with clinical pathways and thinking about where we can change and benefit patient care and healthcare utilisation, and thinking about how we change that and we move into neighbourhood delivery. And then Sally's going to give you the approach that's being used in Camden as one of our place settings, which is really focusing around the creation of the physical integration of an integrated care team. So we're going to split our time in half, but you're going to start with me. So I'm going to talk, next slide, please. I'm going to just talk quickly about North Central London, where we are and our population. So you can see on the screen the sort of bottom half of England and the London bit in yellow, and we are number 25, the top middle of the yellow blobs in London. We have approximately 1.8 million residents, and we cover 5 boroughs, places. So we have Camden, Islington, Barnet, Enfield and Haringey. And geographically, we stretch as far down into Tottenham Court Road and all the way up to the M25. And then obviously we border North East and North West London. It's the second most deprived ICS in London, and it's a relatively young population. And on top of our 1.8 million residents, we have a lot of transitory residents within that as well. So we have a lot of students, we have a high population of universities and higher education facilities. And we also, and particularly in Camden, have a high number of homeless patients, which also then impacts on our high levels of mental health challenges within our population. More than 1 in 5 people in NCL live in the 20% of most deprived areas nationally, and then another sort of 1 in 3 live in the second most deprived areas. So we have a high population of health needs and health inequalities. We're ethnically diverse, but I don't think we're any more ethnic or less ethnically diverse than probably you'd find in other parts of London or elsewhere in the country. But about 20% of our population have an Asian ethnicity and 20% from a Black ethnicity. But what's quite stark is that's a very tiny geographical area on that blob 25, certainly compared to some of the areas surrounding it. And even within London, we are geographically the smallest of the 5 ICSs. But there's nearly 20 years difference in life expectancy between the most and least affluent areas in NCL. And that's within our area. So parts of that we have Hampstead, and some of the kind of the wealthiest parts of the country sit within our patch, and we have the most deprived areas. And you can kind of literally walk between the two of those relatively comfortably. So 20 years is significant. Next slide, please. So our provider collaborative is an all-in provider collaborative. And one of the reasons we're an all-in provider collaborative is that last comment about the level of difference between in our healthy life years across our population and our health outcomes. So the names that you can see on here, this is all of the different providers that are part and members of our collaborative. So we have some incredibly well-known names across the country. So Gosh, Moorfields, UCLH, and we also have ones that are kind of perhaps a little bit more sort of local to us, so the Whittington, and we also have North London Foundation, Mental Health Foundation Trust, which was Camden, Islington and Barnet, Enfield and Haringey mental health trust that came together quite recently. We have 2 community providers, but that isn't the only community provision we have in our system. So CNWL that Sally comes from supports Camden, CLCH supports Barnet, and then Haringey and Islington are supported by the Whittington, with Enfield having a mixed picture as well. So we have a lot of providers within our landscape, and everyone came together in 2021 to form this all-in alliance, really to help drive change at a system level, with everybody being brought into it. And I would say one of the most important partners in our collaborative is the bottom right-hand corner of the screen, or left-hand, depending on which you're looking at it, which is our NCL GP Provider Alliance. And they are the provider alliance for our 32 PCNs, which covers 186 GP practices and 6 different GP federations. And they come together as this GP Provider Alliance, which means we really hear and understand the voice of the GP when we're bringing all of our systems together. Next slide, please. So as I said, we started with a kind of clinical pathway approach, and how do we bring neighbourhoods together, and how do we improve our kind of care around it, looking at data. So our case for change started with the fact that we have, since the start of the pandemic, seen an increase of around about 21% of people with 3 or more long-term conditions in NCL. Our total population is forecast to grow by 1% by 2030. But long-term conditions cohort is forecast to grow by 8%, so nearly 25,000 additional people in the same time period will be diagnosed with a long-term condition. And for the vast majority of those, they're probably already on the way to having those. These are, so we can project quite a large impact on our health and social care services as we go forward. These patients account for around about half of all GP appointments, 2/3 of outpatient appointments, and 70% of hospital bed days. The graph on the screen is probably really difficult to see. I know the slide's being shared, so you can make it bigger. I'm very happy to share this around. So this is some data that we looked at around and the plurality of our patients in the number of providers that they see. So you've seen that we have a large number of providers in North Central London, and we wanted to understand, if you started with we have a large number of people with long-term conditions, and that number is going to grow. We know from talking to patients, we know from work, say with the Richmond Group of Charities, that people with long-term conditions really struggle with the amount of healthcare that we are trying to give them. So 52 weeks, 68 appointments, you know, lots and lots of healthcare. What we want to do is understand how people access that within our system. So on the screen, you can see a blob that's circled in red at the bottom, and that's the Royal Free Hampstead site. So the Royal Free has many sites, but this is its original site in Hampstead. And there are 8,000 patients on that part of the bar chart. So those are patients who last year only went to that site for their secondary care. So this is only secondary care provision. So 8,000 only went to secondary care. You will then see along that line, there's lots of other blobs that link to lots of other blobs. And that's our uptick chart that shows patients who also attended another site or at least one other site. There are 80,000 patients in the same time period who were seen at the Royal Free Hampstead site and other sites, including outside North Central London. So we know our patients spend a lot of their time going to different places. So we wanted to come together to think about how we made that care better and think about how we link it to care closer to home. Next slide, please. So we started with a collaborative working approach. So we set out to develop a test and learn approach around improving healthcare and healthcare utilisation. One thing I didn't talk about in our provider collaborative is, and you will notice on this slide, is UCL Partners, who are our health innovation network. My team is a very small team. We have a team of 6 who are funded directly by the providers, and we are part of UCL Partners, so we sit within the health innovation network. And that allows us to be quite agile in our approach and bring in innovation and transformation, and do that alongside NHS organisations. We have a very transformation approach to things. So we secured executive sponsorship, so our chief execs, both across our providers and our ICBs, including our exec director of Place, were all very supportive and vocally secured the sponsorship of this, which allows us really to kind of go into organisations and say the chief execs are supporting us and directing us to do this. We engaged clinicians, so we started with the problem. We then brought clinicians together, including consultants who work in integrated care sessions, primary care leaders, mental health consultants, and more and more. And we brought them together to think about how we together found a solution, rather than people like myself sitting in a dark room and kind of going, how do we take policy and turn this into action? It's like, clinicians, how do you want to do this differently? We used a data-driven approach. You've seen some of that with that graph. We looked at population health, healthcare utilisation, and we service map, so we can understand the variation across our system in terms of the number of patients with long-term conditions and where they live, how we link that to deprivation, how we link that to age, how we link that to ethnicity. We can also link that to other population information, such as working age and unemployment. In bold, I would say that, so we started with data-driven in-person workshops, the power of bringing people together in person and having a kind of 4-hour session, of which I think we probably had an hour where we just gave everybody coffee and biscuits and let them kind of just have that time together. And the number of people who'd never met, and I know we all know that because we all work online, you know, much more than we used to, but these are people who've been in the system pre-COVID, who'd never actually met in the same room together. So bringing those people together and just seeing that kind of energy and seeing that development come together. We then developed and refined the approach, both and kind of took that back to operational leaders and ICB leadership. And we also have a lived experience group. That then is focused and the work is driven through our executive and operational leadership, with system clinical leadership and ICB leadership. Next slide, I'm going to touch on this very, very quickly, which is our clinical model. Oh, no, it's not. It's building the team. So we now have 5 PCNs worth of teams. So we start with PCNs, and a consultant links to each PCN. We then have clinical and admin roles that work across all 5 PCNs, and then we link that clinical model into our neighbourhoods and from mental health, community, and our borough-based services. Next slide, please. Very quickly, our model is that we use all the data sources. So we have Healthy Intent as our population health data management, and we have that, and we create PTLs from that and from GP data. We then risk stratify those patients, and those patients are desktop reviewed by the team, so across the consultants and the GPs, accessing every individual different EPR. We then bring that together at an MDT, and then we create patient contact and patient actions. So we are just bringing everyone together, but one of the really important things is looking at it from a population health and then a focused kind of risk stratification. Next slide, please. The challenges for this, so I don't think these will be unusual for anybody, but digital access. So our clinical model relies on all clinicians being able to see the full detail of patient records. The London Care Record, for anybody that's used to it, only shows a summary of information from some providers. So each clinician in that group has to have EPR access. So we have 32 data sharing agreements in place already. We have a different from data, we have healthy intent versus our locally commissioned service data. So we have a different pool of information. We've developed new risk stratification, so we're developing a case finding methodology and thinking about the opportunity to test AI. Workforce portability is a huge challenge, and I'm sure Sally will talk about this as well, but the number of honorary contracts that our team need in order to work across the system, and also releasing staff to work in different ways. Each PCN has a slightly different approach, partly because they have a different population, but they also have a different leadership approach within that. And we also see variation in place-based services. So we have community diabetes services in some boroughs, but absent in others. The availability of social prescribers and links to VCSE groups with some and with others. So when we're kind of thinking about how we support these patients with complex long-term needs, it's really challenging if there's variation. Next slide, please. And then I'm going to stop and hand over to Sally. So by the end of January, we'd done 5 PCNs, we'd reviewed 86 patients, and we'd found about 75% were the right patient cohort. We've been able to at 43%, we're now rising to over 60% of the patients reviewed have a secondary care appointment cancelled without generating new referrals. But the most common thing we're doing is linking to specialists, resulting in preventative actions and meaning we don't have to grow referrals. And then that real drive into social care, mental health and community teams, and thinking about and working together to think about how those patients then get held and supported in neighbourhood working. So really kind of pushing it down and that left shift. So my final slide is we were asked to think about the key messages we would give everybody. So it was 1 and I cheated and there are 3. So use the data to know your population, be tenacious about solving the system barriers. So 32 data sharing agreements and 7 honorary contracts per member of staff takes a lot of effort, but it's absolutely worth doing. And then being clear about the purpose and keeping stakeholders on track. Everybody has a different idea about how this could work. And that's what we're starting with, is the way we're working and sticking to it. So I'm going to stop talking about my part of the world and hear from Sally.
Fantastic, Kate. Thanks so much.
Hi, I'm Sally. I'm the operational lead for Camden Integrated Community Health. So I manage district nursing, community therapies, the vaccination hub, Twilight team, a UCR as well. So we have had a strong focus of working in integrated neighbourhood teams. And the reason why we wanted to do this was to tackle deep-rooted health inequalities in Camden, to improve people's physical health and mental health outcomes, to have joined up holistic support, improve the experience of our local people, create better working environments for our staff by knocking down the barriers when it comes to working with our patients, developing local solutions for big health challenges, which is the mantra of our neighbourhoods, and enhancing productivity, making our services absolutely seamless and collaborative. And we wanted to stop silo working, maximise prevention and maximise the opportunity of innovation. Sorry, can go on to the next slide, sorry. How we would achieve it is multi-agency model of practice, which is sustainable, creative, integrated. We're building upwards from community ownership, which is the key important part of neighbourhoods, is that your services belong to the neighbourhood, that a neighbourhood itself helps to develop them, and we work in a very co-productive way. So that we're adaptable with our core offer, and our primary focus really is on the frailty, long-term conditions, and the agenda for hospital avoidance. So the next slide shows us the key drivers. They're both national and local, with a fuller stocktake report written in 2022, Darzi. They highlight the need to put our services into a neighbourhood footprint. We have a 10-year plan in London that was launched in January that all London services should be going into neighbourhood models of practice, and that is looking at co-location preferably. So in Camden, we're a little bit ahead in that we've started this process already. We have the Camden Health and Wellbeing Strategy to stay well for longer. This really does look at start well, live well, age well, and it really places the resident in the centre of our community. What's support for our residents? Where are they in their life cycle, their experience of actually living in Camden, the places they go, the places they can access, who can reach the services, who can't. This is about reducing health inequalities. So in order to manage our neighbourhood project, we had a strong operational structure, which is on the next slide. We had a Camden Integrated Executive Board, which were all the execs from the statutory agencies that got together to create the vision. And the steering group, which I sat on, and I was also part of the leadership and staffing, as well as the neighbourhood working group. But we've had several groups behind this. So one looking at data, which is an extensive piece of the project work for across all our services, what the operating model will look like, the comms, how we're going to engage with our population, estates, the governance and our digital interoperability. So our vision within CNWL was to realign to begin with our district nursing and therapy skill mix. We thought this is a good place to start because it's the largest workforce that we could maybe move out into 5 neighbourhood teams. We also really knew that our GPs really wanted to be co-located with district nurses and community therapies again. So we felt this was the best quick win place to start. We had 3 large integrated district nursing and therapy teams. So they were integrated already, and we had 3. And it was a challenge because we've gone into 5 neighbourhood working groups. So I had 143 staff and had to host a consultation. The consultation was really significant because it had impact on staffing, so all your HR impact and what happens to staff and managing that change. But on top of that, it's clinical impact because it's the clinical workflows, how we act and the travel of patients around the services and how we're going to safely do things and manage the governance. We had an ambition that the first INT would be set up in the East neighbourhood at the end of 2024. We did go into a 5 neighbourhood footprint of working in July, and we co-located in the East neighbourhood in the beginning of October. So it's quite new, and we're having a test and learn approach in our multi-agency team, which is resident focused, and we really are looking at hospital avoidance through the frailty hubs and the NDTs. The partnership working has been really key. Building in relationships has been the most important thing through this change management. And the vision has been integrated between health, council, the community and the community itself. So the operational structure, which is on the next slide. So we had to have a clear vision, look at how our caseloads were developed, how our systems and processes and the training for integration of our staff in all the statutory, separate statutory community organisations. We also brought in our voluntary sector to the fold as well. Camden has a really strong Camden for Carers organisation, advocates for mental health. We also have places like the Chinese Centre, the Irish Centre, a lot of social prescribing has been up and running and quite solid in Camden. So we had to engage them too. We wanted to avoid overlap. We want to promote self-care, safety netting and resident-centred care. And so developing the strong partnerships between the voluntary and statutory agencies in preparation to go into neighbourhoods was really important. So if we move on to the next slide, the key elements of the INT really is resilience. It's about a purposeful, consistent connection around people's lives, how we bridge the gap, how we bridge the communication between the voluntary and public sector. Our Camden residents, when they did the research from the Health and Wellbeing Board, were very clear that they wanted a streamlined care and they didn't want to have to repeat themselves when they went to see different people. So it has to be person-centred, driven by the population. We looked a lot at health needs analysis data. And that happened both across Camden and within the different statutory organisations. For example, within my organisation, I had to look at the caseload, length of stay, discharges, admissions across every single area on the map to work out what my skill mix and staffing would be across the therapies and district nursing. Co-production, outreach and early identification, mitigating the risk and optimising our assets. The idea is that we have better staffing capacity because we should be working more together with more focus on problem solving. And one of the key parts of it was enhancing professional curiosity, which I think we're already seeing the benefits. So the next slide is, so we had a really good ready-made foundation across our voluntary sector. With we already had some active neighbourhood hubs and huddles that used to meet, and this was very well modelled by Children's Centre Services, who were already in the team around the child, using schools and children's centres around children's and families. So Camden has always worked in a very rich partnership collaborative way. A lot of the relationships were there already. We have very strong GP support to go into neighbourhood working. And as I was saying earlier, the resident feedback was that they wanted their care streamlined and coordinated. And we have a very strong vision to embrace managing long-term conditions and strong investment from the GPs and the PCNs to look at that. We have a very wide core offer of services. So to begin with, from health, district nursing and community rehab therapy are the first teams to co-locate, but we know that we have a much bigger core offer that we can further think about. Collaborative partnership working with hospitals, pharmacies. We develop roles of allied health professionals in Camden, strong social prescribing and very good evidence of the demographics and health inequalities data. So moving on to the next slide, you can see our neighbourhood footprint. So I had 3 teams that were beginning. We had the Belsize team, which was just at the north of Camden, and then the Gospel Oak, which was down the right-hand side of the map, and Hunter Street, which was across the middle of Camden at the bottom. So as you can see, all my original teams overlapped already where these colours are in these 5 neighbourhoods. So I really had to shake up 3 teams completely and split them into 5 neighbourhood teams to get them ready to mobilise into integrated neighbourhood teams. We really looked at the data for all of them, and every neighbourhood, although we can see the health needs of Camden across, and it's a very diverse borough, each neighbourhood, when we look at health, had slightly different needs. For example, in the north of the borough, we've got a lot more isolated housebound elderly in large houses, can't travel, can't get out. In the middle, for example, which is more as central, which is nearer the King's Cross area, we have a lot more high-rise blocks of flats, more deprived living, more drug and alcohol use. So these are all the things we had to think about when we had to shake up our skill mix and put them in the neighbourhood teams. So who is in our team? Well, the East they co-located in October. They moved in together in Kentish Town. So they are a large team now, all on one floor together in one office. Social workers, we've got community mental health workers. The GP partnerships are spread. We've got GPs spread across 3 practices, but they really are visiting every day, and they have what's called the tap on the shoulder approach, where they go up to our 2nd floor and they approach whether it's a district nurse or a therapist or whoever they need to talk to and ask them in conversation. So home care, social prescribing, district nursing, community rehab, and our administrative staff as well. Also, when we went into our neighbourhood model in CICH, as I said, I've got my 5 neighbourhood teams. I've also got peripatetic roles that go across the borough. So I have peripatetic visitors that also visit the neighbourhood that work across. So in order to do this, the planning behind it was quite extensive. We had our own large consultation to manage, looking at our workflows, working with our staff, but also we came together with social services and mental health and the voluntary sector and really talked about what our vision was for moving into these teams. So I had to split my service into 5 teams ready to mobilise. One has mobilised and I've got 4 ready to go, but they're already working in a neighbourhood caseload footprint. I had to work really closely with HR. Staff side were very proactive in this process. The transformation team, our finance team, because I had to get the skill mix right, the budget right. Estates, the data analysis team were really important in all of this. And we need to revisit the data now we've been in neighbourhoods for a while. We had a series of drop-in meetings. I had one-to-ones with HR, every single staff member, a live question and answer document that I had on TrustNet, that I had to answer the questions every day as we were live, several webinars, and multi-agency steering groups. And we had a lot of post-it note, flip chart type activities to try and get staff the best they could to be part of the change, to influence the change, to say what they wanted. So moving on to the next slide, you can see the stages we've been through. We've been through co-location. We set ground rules. We had get to know each other days, tap on the shoulder, share and learn lunches. It's hot desking only. We didn't want any of the services to be territorial. There was actually a lot of discussion around that, whether to split the office into the different areas, but no, it's hot desking, mix and mingle between social services and health in particular, who are the 2 largest teams in the area. We've had the working together reflective practice days, so a lot of shared learning, and the staff benefited from a lot of training through this, understanding each other's services. What does a good referral look like to social services? All this kind of learning. What does a community rehab therapist do? What can they offer? What's the difference between an OT and a physio? I share an office with you. That kind of training. And now we're in stage 4, which is really looking at the MDT SOP. We're looking at what the workflow looks like, the frailty hubs. And this week, they've now decided to sit in a row. So we have a clinician of the day where all our calls and triage goes through. Social services and mental health have similar, and the social prescribers have similar. So this week, they're sitting in a row together. So they're receiving their referrals and they're collecting some data to see how much of it is overlapping, and is it going to be possible now to have some kind of centralised email, phone number, so there is only one referral pathway into the neighbourhood. That could be a really exciting way forward. So additional things we really had to think about. Estates was huge. Key passes for district nurses, parking. We had 7-day opening times in district nursing and rehab, and the building was not originally insured for the weekend. So we had to go through a huge process so that the staff can be in at the weekend. Managing the different Wi-Fi, the shared spaces, private meeting rooms, which we've set up. So we've got a large meeting room for the MDT, but there's private bookable meeting rooms for people to have their one-to-ones and that kind of thing. The integrated business continuity plan, finances, governance, how we manage patient information, caseload alignment on system 1 has been really enormous because we're now in 5 units. Moving all our staff, so staff records as well, ESR, rostering, job titles, aligning our leadership across the hub models. So historically in my 3 teams, I had a therapy lead and a district nurse lead for each of the 3 teams. So 6 Band 8As. I was going into 5 neighbourhoods. So now I have 1 Band 8A manage each of those smaller 5 neighbourhood teams, and a practice development nurse that works across the borough, because we think that the risk in district nursing is higher, and we wanted to define the scope of clinical practice in district nursing moving into neighbourhoods. So through that, we actually had to teach therapists how to lead district nurses and district nurses how to lead therapists. So we had a really interesting time. Creating a practice development role has been really important to us, and actually it's brought in some real innovative change in district nursing, developing crossover leadership, and we had some peripatetic roles that we had to refine. For example, there's only one pharmacist across the borough. How are they going to work with our neighbourhood teams? And refining our referral pathways. So this is our timeline. So you can see we went in, planning started in 2023. We mobilised in the summer, we co-located in October, and now we're in this next bit of the test and learn. And there is a lot of background work going on to work out how we're going to get our measurables. There's a public health analyst who's been employed to look at this, because you imagine measurables in the NHS look different to measurables in social care. So it's like, how are we going to refine those? We're looking at lengths of stay, discharges, outcomes for patients, reduction in pressure ulcers. Was there anyone that we did avoid them going to hospital? That kind of data. What we benefit from is really the early recognition of the soft signs of deterioration. We've had a lot of learning in my organisation about escalation in district nursing and therapies, and how we work with carers and carer agencies when patients deteriorated. We've actually got a QI project that looks at the triangle of care and care champions. So how we in health are sharing our skills with News 2 scoring and what social services can do to help notice these things. So cross-fertilisation, joined up home visiting of hard to reach patients, especially when you have no access, mental health problems, zero tolerance. You can go with a member of social services jointly rather than have two health professionals go. So we've had an improved standard in our referrals, so they're a lot more slick. We don't have to reject as many, because I think that each other's services are understanding more what they want. When we're doing social services safeguarding referrals, they don't come back as with many questions, because our clinicians understand really now what the social workers need to hear from them to be able to assess a patient properly. Prompt support, efficient escalation, more joined up working with the care homes. We've actually brought Marie Curie into the fold as well, and they're working now as part of, they've actually joined the North neighbourhood where we've got space, but they've seen the benefits of releasing district nursing capacity and working together. Now we've been in this format for 6 months, we're going to relook at our data and our numbers. So the learning and the challenges, we're using the test and learn approach, delivering it with staff, and the multi-agent discussion was really, really important. There's been a key theme arisen about complex care nurses. So we need to define their measurable outcomes a lot more clearly. And we've learnt this from neighbourhood working. We can't really see what complex care nurses do. We see what district nurses do, but not so much complex care. And we realised that that was affecting district nursing contact data. So that was a really important thing that we've learned. Co-location has had a great benefit. We didn't have any redundancies or pay band changes, and every job role we've managed to rescope it across our neighbourhoods. We did realise we needed a hub model. We didn't have enough therapists to fit, but there's not enough OTs, for example, to go between 5 neighbourhoods. So we've had to buddy up some. So we've got some split roles. For example, North neighbourhood is hubbed with West. So there's a bit of mixing and sharing, and it was really important to have a very tight supervision matrix across the borough, because you don't want people in isolated job roles where there's less of them within that neighbourhood. For example, you might just have one OT in a smaller neighbourhood. Well, they need to have supervision with a senior OT from another neighbourhood. So that had to be really, really tight. Change management, regular comms was really important. As I said, upskilling, and our therapy leads and nursing leads respecting and recognising each other's leadership, because it is about leadership, and ensuring robust supervision. So the key messages I would say is the importance is realistic timeframes for each stage. Work out how long you think it will take. Add generous contingency. I would say get a dedicated project manager. I ran it as the operational lead, but I had many other services to lead as well. So it was quite a undertaking, shall we say. Anticipate significant change for change management throughout and after the project, and really important to keep your eyes on the prize, because the community health provision is really worthwhile, and that's how you get your staff to engage, to see how it's going to benefit their patients. Thank you.
Thank you so much, Sally. Talk about eyes on the prize in terms of really demonstrating how many benefits there are to be realised and how much progress you've made. And I thought it was particularly inspiring to see that picture of everybody together when Kate had, just flagged in her section that often people had worked together for a long time and never met. So it just shows kind of very visibly the scale of the kind of transformation that you have been leading. So thank you both to both of you. It really is inspiring stuff. I wanted to just go back before we focus on our next case study. I want to just go back to India's great question in the chat. And India, do feel to come in after this. So just that question in terms of the model and your link with one secondary care consultant aligning to each of your 5 PCNs. Could you, and whether that's part of a kind of triumvirate leadership structure, could you say a little bit more about how you arrived at that model? And others, do feel free to pop questions in the chat, or I'll come and bring you in if you want to wave your hand.
Thanks, Annie. Yeah, the approach we took was, we often find within our boroughs that we have lots of GPs that speak to lots of different consultants, and we find that we have a lot of really good relationships that form, but actually it's quite challenging to then try and manage that through a provider kind of approach and really streamline what we're doing. So we wanted to try and think about sort of single points of contact to make it easier both in and out of our organisations. The thing we ask our consultants to do who link with the PCNs is we ask them to work with the multimorbidity hat on. So we have a clinician who's fabulous in this area. She's a respiratory consultant by profession, but she really works in that general medicine way. We similarly have a kind of renal physician, a diabetologist, and we ask them to think about as they link with the GP, how broad they can be within the comfortable scope of their clinical practice, and then pull in others. And that really helps us also reduce the number of individual organ referrals that we're seeing. So we have that sort of single point of leadership for that PCN from secondary care, who also is able to do a lot around that kind of clinical discussion for that individual patient population, who's then got a wealth of consultants behind them that can help that. And we find that kind of single approach helps. We are working to understand whether that's possible to have a single PCN lead who could do a very similar approach, or actually we still need to have that kind of more individualized GP approach. So it's what we're thinking about is the scalability. So at a PCN level, it works. Where is it we can go scalability, and where can we think about do you still need to have other consultants who are kind of linked into that PCN for more specialist care for patients?
Fantastic. Great question. Thanks, Kate. Just a question from Nick in the chat, and then we'll move to our second case study and then have more chance for questions at the end. So Nick, just thanks for the fantastic insight, which is absolutely right. So do you think you'll increase the number of community pharmacists? One doesn't seem to be enough for such a diverse area and large INT team. Any thoughts on that one, Sally?
Yeah, really it is challenging with pharmacy. We do have a community pharmacy team, and I had one allocated to my services that was working across 3 anyway. So obviously I had to move that role across 5. But actually we are hoping that working more closely with the GPs, maximising the pharmacy support that we can access through GPs that we didn't have before we were in neighbourhoods.
Great question. Thanks, Sally. Alistair, I've blocked your question, but I hope it's okay to just bring in Nick for his case study and then just loop back, because I'm conscious some people may need to drop off the call at 3. We've got till 3:20, and I don't want people to miss our second case study. So Alistair, I will come back in a moment to you. So Nick is just going to give our outlines from our second case study, Nick, Joint Chief Strategy, Transformation and Partnership Officer in Dorset, and they are at an earlier stage in their journey, but lots of insight to share. So over to you, Nick.
Yeah, thanks, Jenny. And slightly nerve-wracking to follow all the good work that Kate and Sally described there. But what I'll do is just talk to you today about what we've been doing in Dorset on our integrated neighbourhood teams programme and how that sits within the provider collab and place space. I'll say a little bit about Dorset, a bit about our provider collaborative, and then how we've approached development of INTs. In terms of where we currently are, we've got 4 integrated neighbourhood teams up and running, and we have 14 other integrated neighbourhood teams who are established with the leadership triumvirate, and we're developing plans for each of those for 25, 26. But I don't pretend with the title of this seminar being, I think, effective integration across place and neighbourhoods, that we've solved this or that we have all of the answers. But I'll certainly kind of talk to you about what we've experienced. So just sort of very briefly, in terms of Dorset, it's about an 800,000 population county on the south coast of England. It goes from the east, Christchurch, right across to the west, which is Lyme Regis. You might describe it as seas and trees, so there's rurality, but there's also coastal areas, and with all of that comes the rural deprivation, coastal deprivation. But we also have some real areas of affluence as well, sandbanks being the kind of the one that is often name checked. We have a really elderly population. There are various systems in the southwest that all claim to have the eldest population. So I will make that claim and let someone else come in and claim that it's them instead. But it's certainly an elderly population. Christchurch, I think, is definitely got the kind of the highest proportion of over 85s in the country. And there's a split of healthy life expectancy of about 10 years from the most to the least deprived, and a real difference in needs across that kind of that county. And the different areas as well. We've tried to develop a system which is based around people and communities, with the with providers, healthcare, local authorities really focused on that rather than their organisations. We have in Dorset 1 ICB. We've got 2 acute providers, University Hospitals Dorset and Dorset County Hospital, who primarily work across the east and the west of the county. And then we have Dorset Healthcare, who is the community and mental health provider who works across the whole of the county. We've got 2 local authorities, BCP and Dorset Council. And again, generally BCP is towards the east, Dorset towards the west, and therefore we have 2 places. So despite Dorset probably being smaller than some other ICB's places, we have 2 places ourselves. So a Dorset Council place and a BCP place as well. Again, if we just move on to the next slide, please. The fact that we're trying to build our system around people and communities, we think, is reflected in our ICP strategy, which sets out some key priorities. And actually, to develop our ICP strategy, we went through something called 10,000 Voices, where we did a big community engagement piece, where we tried to ask the question of our communities and populations along the lines of what do you need to stay healthy and well, rather than starting at it from a kind of a health perspective or a service perspective. And actually that drove the kind of the conversations around prevention, thriving communities, and for us to work better together as well. And again, if we just move on to the next slide, please. And one of the key delivery vehicles to deliver against the ICP strategy and the forward plan that we've set within Dorset is the provider collaborative that was established in 22. I think if you kind of looked at the spectrum of different ways that provider collaboratives could be established, we're kind of towards the left-hand side, the more informal side. We have effectively what we call our Dorset Provider Collaborative Leadership Boards. We have a provider collaborative agreement which sets out our values. We've got dedicated resources towards it. The formal members are University Hospitals Dorset, Dorset Healthcare, Dorset County Hospital, and the GP Alliance as well are actually now a formal member despite this slide. And our GP Alliance are representatives of the 18 PCNs and the 90 odd practices that we have across Dorset. So again, we get a good collective one voice for primary care, which is really positive, and they are a full member. We invite others in, so VCSE, local authorities, etc., but it is primarily an NHS focused provider collaborative. There's a chairs and NEDs oversight group. We haven't delegated any authority into that provider collaborative yet, but that's certainly the intention as we go forward. Initially, we set out a number of priority programs around agency and temporary workforce, around clinical acute networks and shared services. We've got therefore some really good progress has been made in how we deliver orthodontics, how we deliver rheumatology across the county, rather than being organisation specific. And we're in a place where we're starting to bring together our corporate support services as well, whether that's procurement or estates and facilities. So all of that is being driven by the provider collaborative. And we also adopted a number of other collaborations that were already happening within Dorset. So, for example, we had One Dorset Pathology, and we had community diagnostic centres work. So that all now sits under the remit of the provider collaborative. When we initially set the provider collaborative up, we left a placeholder for sort of other big system service transformation. And we were very clear that the provider collaborative was there to do big strategic service transformation. It wasn't there to do kind of day-to-day performance management. And I think we've stuck to that. And as the neighbourhood agenda has developed, the provider collaborative has picked that up and is overseeing the delivery of the integrated neighbourhood teams programme. So again, if we could just move on to the next slide, please. So the development of the neighbourhood teams sits within the provider collaborative, and effectively what we are trying to do with integrated neighbourhood teams is bring together primary care, community, mental health, public health, voluntary community services, and services for children and young people, based around natural communities, focused on tackling health inequalities, coordinating teams, building co-production skills, and an understanding of local community needs. That is a joint programme which is led by Dorset Healthcare and the GP Alliance primarily, but with the ICB engaged as well. I'm the SRO for the programme, but I have three sponsors, as it were. So the Chief Executive of Dorset Healthcare, my boss, plus the chair of the GP Alliance, plus as well the Chief Executive of the ICB, which I think is often a pain, but also I think is reflective of the complexity, but also the buy-in and the importance of developing integrated neighbourhood teams across the county, and is a reflection of how everyone wants to be engaged. And the programme, I think, reflects that commitment. One of the other things that we're really clear on is what we're not doing with integrated neighbourhood teams is adding a new layer in and calling it an integrated neighbourhood team. We're not trying to fund new roles and call them integrated neighbourhood team roles. And we're not trying to relabel things that we were kind of already doing and just say that's integrated neighbourhood working. What we are genuinely trying to do is bring together all of those disparate existing teams that operate within neighbourhoods and within communities, and improve the way that they work together. And therefore, by doing so, we think that we can deliver much more with the resources that we've got within the integrated neighbourhood communities. And again, if we just move on to the next slide, please. One of the things that we experienced when we were going through the early scoping of the programme was how development of neighbourhood services linked in with place-based partnerships. Now, within Dorset, we don't have very mature place-based partnerships for sort of multiple reasons. And one of the things we kept running up against as we were developing neighbourhood teams is people trying to play in what I would call place-based issues, focused on, big social determinants of health elements, whether that's transport, housing, etc., and expecting the integrated neighbourhood teams programme to solve all of those problems as well. And there's an argument for that, don't get me wrong, but actually there's something about how you eat the elephant. And what we were very clear on is that within the integrated neighbourhood teams programme, that was a component of the wider place-based agenda, but it wasn't the whole of the place-based agenda, and that's something that we have to keep coming back around to. So it's not that we don't have an ambition to really make a difference within the place space, but it's just that actually we need to recognise that there's a whole host of other things that feed into that as well. Again, if we could just move on to the next slide, thank you. And just on that theme, one of the other conversations that we've had as we've been developing the program is how you get to the place where you're really focused on operating in that proactive social determinant space, which is the ambition, where we do want to help create social capital, because by doing that you can develop communities, and therefore communities can take more responsibility for their own care. That's absolutely the space we want to be in, but we need to recognise, or we recognise certainly within Dorset, that there are steps to get towards that. So what we've been focused on is building integrated health teams so that the NHS works better together, so we can work better with others, that we then build integrated health and care teams, and then we expand that to building integrated neighbourhood teams with wider public services as well. So that's the sort of the horizons or the steps that we're trying to run through over the next couple of years. And again, if you just move on. And another challenge has been differing voices on do you just kind of tell local communities, local teams, set up integrated neighbourhoods and get on with it and just kind of leave them to do it, or do you take a very prescribed approach, with a sort of a very kind of fixed view as to what they should or shouldn't be doing? And I'm sort of being facetious to sort of just to kind of make the point. What we've tried to do is get to a place where we've got a balance between autonomy and alignment. So we want and recognise local variability, and the integrated neighbourhood teams need to meet the needs of their local communities and populations, but we don't want 1,000 flowers blooming either, and therefore we've tried to develop a framework within which they work within, and that kind of sets that out. Again, if we just move on to the next slide, please. And one of the ways that we've tried to balance the autonomy and the alignment is by setting a sort of set of design principles for then the local teams to work through and think about how they do that. So supporting natural communities that people of Dorset identify with, but giving them some ideas of the likely boundaries based around PCM boundaries initially, but recognising the importance of wards and other natural communities as well. And we've really also focused on the fact that we think this is a culture and ways of working piece, so culture and process piece. And we're looking at how we support on that cultural change piece, as well as the process change, process improvement element, supported, underpinned by digital. And again, if we just move on to the next slide. Again, being sort of mindful of that local variation and recognising that there will be some neighbourhood areas in places where they have shared priorities. So they've absolutely got to work together on those things. And also we need to be mindful that when we design neighbourhood teams, they will need to interface with acute and specialist services across the county and with the acute hospitals, etc. And we can't have a situation where our acute teams are trying to work in 18 different ways with neighbourhood teams. So we need some consistency across the two, and we're trying to find the balance again between those two things. So thinking about what you do at a place level versus what you do at a neighbourhood level. And again, if we just move on to the next slide. One of the other things that we've been really grappling with over the I guess the past 4 or 5 months is I guess what the business case is for this. And interesting, if people will have read the neighbourhoods services guidance, which talks, I think, a lot about the metrics and how you measure these things, and I think that's sort of partly people intuitively recognising the value and the importance and the difference that development of neighbourhood services could make, but not quite having a sense of how we really capture that. So within Dorset, what we've done is looked at a logic model for our approach to the whole programme, really, which focuses on a kind of a logic which says if you activate staff, so if you give staff the autonomy and the confidence and the capacity to change the way they work, then actually they're more likely to be able to work differently to improve the systems, processes, and how they work together. So they're much better able to think about how they do referrals in a different way, for example. And if you do that and create the space, then they've got a much better chance of activating citizens. And we know that, again, if citizens are more engaged in their own care, that there is a real benefit in terms of outcomes, but also in terms of activity and demand. And what we've done is we've developed the business cases effectively attribute metrics and quantified the benefit of doing all of those things. And again, if we just move on to the next slide, and by doing so, we've been able to quantify the activity impact or the benefits of developing sustainable, cohesive, integrated neighbourhood teams across Dorset in terms of the metrics. And we've now been working with the ICB on how you cash those benefits, as well as the kind of the non-cashable cost avoidance type stuff that we're more used to, I think, within this space. And again, if we just move on again, please. So that just allows us to, that's just a demonstration of what I was talking about. So we've tried to quantify the cash releasing savings over the next couple of years. The other thing that we're not doing within the business case development for neighbourhood teams within Dorset at the moment is make a big play for a big transfer of money from the acute, so the big kind of left shift of resources. What we're doing here is identifying the benefits of the teams that are currently there, the people that are currently there, the resources that are currently within communities and neighbourhoods working much better together. And if they work better together, we think there are these benefits. And we're confident that we can get to a place where they're demonstrating that over the next couple of years with a relatively limited amount of investment. And actually at the point that we've proved that concept, then actually we're looking at developing another business case which says, okay, look, we've proved this, you can see the benefit. If there's a bigger shift in terms of funding from effectively from acutes into community and neighbourhoods, then here's the additional benefit that we can achieve. But we're not trying to kind of make the one big case all in one go as well. And then just final couple of slides, I'm conscious of time. Again, just linked to that kind of business case cashable savings. These are the kind of the metrics that we've now set to kind of track the impact of developing integrated neighbourhoods teams. I think back to the previous speaker, recognise there's probably some things in there that local authorities don't necessarily don't resonate with local authorities in the way they do with the NHS. Again, as I've said previously, we've taken a view that what we're trying to do is develop the NHS neighbourhood health services element, and in parallel we'll start engaging with local authorities as well, because we know there are significant benefits there. But again, we're thinking about the steps and the approach to getting to the kind of the promised land rather than trying to do it all in one go. And then I think this might just be the final slide, if we could just move on. So this sort of brings us full loop back round to the provider collaborative structure that you saw previously. This just shows you the programme structure for integrated neighbourhood teams within Dorset. I just wanted to pull out a couple of things so you can see the connection into the Our Dorset Provider Collaborative. As our place-based partnerships establish themselves and become more coherent and more focused, because we're not quite there in Dorset yet, then we would anticipate that the integrated neighbourhood teams work starts to shift into that place, or that there's a connection between the two. And ultimately the ambition within Dorset is that those place-based partnerships sit really closely in with the health and wellbeing boards within the two local authorities as well. So we set sort of back to the kind of that point I made earlier, integrated neighbourhood teams is absolutely a component of wider place-based working, but it's not the whole of place-based working, and it absolutely has to be delivered in terms of a provider collaboration, and therefore actually we think the connection in at that point helps to drive the change in ways of working as well. So I'll pause there. Happy to take any questions, but as I said, conscious of time.
Fantastic, Nick. Thank you so much. Another great example, as you described, of how you're trying to eat the elephant in your neck of the woods, and lots of progress and really clear thinking, and really helpful, I think, to see how you're kind of staging that business case to those two phases of the work. So I'm going to see who would like to come in. Do pop your questions in the chat or comments or raise a hand, and I will just keep an eye out. And then I've got some questions I'll come in with, but a question from Mark. Is the INT Programme Board multi-agency?
Yeah, absolutely. NHS partners, system partners, local authorities, VCSE representatives, etc. as well. Yeah. Most of the people that you would expect to be in the room are in the room.
Good question. Thanks, Nick. Other comments, questions? I know some of you are working on INTs in your own patch, so do if you've got any learning to share. Heather in the chat, really refreshing to hear someone's not focusing on attracting extra money in the first instance, but working on releasing the benefits of collaboration. Yeah, I agree. Heather's really good staged approach. Oh, India, do come on in. Great to have someone.
I started to type it out and it'll just be easier to say.
Yeah, much easier, thanks.
Thanks, Nick. That was really fascinating. And especially the case for change financially, that sort of benefits thinking is valuable to be sort of front loading. But my question was really around the interaction between the provider collaborative, the INT program board and the place partnerships, sort of borough committees and the risk of duplication between those different groups, and how what your thinking is around the clarity around the roles each of those have and how they don't all end up being meetings speaking about the same thing.
Yeah, it's a really good question. We're fortunate in Dorset that, as I said, for various reasons, the place-based partnerships are not up and running in the way that I think they might be elsewhere. And there was a period of time where we were kind of waiting for them, and actually we've just stepped into that space from a provider collaborative perspective. As things develop, the way I see the interaction or the interface developing is that the place-based partnerships via the health and wellbeing boards will set the strategy, the focus for improving health inequalities, across their two places. So whether it might be, I don't know, obesity within BCP, for example, or it might be CAMS or something, and then actually the provider collaborative and the INT program, if appropriate, help drive the change in ways of working between the partners. So that's sort of how I'm conceptualizing it in my head. I think there's still a way to go, and there will be other views available, I think, in terms of how that might work.
Thanks, Nick.
And the provider collaborative sits. Sorry, and the provider collaborative sits sort of behind that as the group coming together in your description.
Yeah, I think the provider collaborative is the engine room for that. We have to work out exactly what the interface is between provider collaborative and place-based partnerships. But I think the provider collaborative is driving the change in the way that we work, whereas place sets a sort of a more commissioning, for want of a better word, strategic commissioning type approach.
India, great question, and very much at the heart of today's webinar. Got a chance for a couple of more questions, so let me just, anybody else would like to come in? Questions? There's only one that question from Tilly. Have the impacts you outlined been considered as part of your planning expectations for 25-26?
They are very active discussions at the moment, and there's two elements to it. There is one, how much of that you build into your plans for 25-26. So do we think that can all be delivered? And we do. The business case is there. There's then a question about where that sits. Does that sit within the provider plan, or does it sit at a kind of a system level? So that's a very active conversation. And then we're also having a conversation, which is a really interesting one, about what's cash releasing and what's cashable stroke bankable, and who's kind of the lead on that, and what's the commissioner role versus the provider role. And again, I don't have the answers, but they're the kind of the very active conversations we're having at the moment.
Great, thanks, Nick. Another good question. Heather, question back to Sally. Thanks for your detailed description on forming INTs. You got a rough idea of how much the process itself has cost? Cut to the chase.
We didn't have additional funds for it in district nursing and community rehab therapy. I think we've had a little bit of investment from the GPs, because the Kentish Town Health Centre was already there. We already had children's services on the second floor, and there was a lot of space that wasn't being used. So there's been a small amount of money that's for the estates, because it's a rentable estate. But the GP, well, I think we're happy to help with that. We've had to purchase a bit of extra equipment, for example, things like Doppler scans and bladder scanners and things, and that's where the expense has been. But we didn't, and this was the challenge, we didn't have any additional funds for any extra staffing. So I really had to look at the staffing I already had to see how I could put them into 5 neighbourhood groups. And that was actually really, really difficult around the data. And then that was before some of the financial climate changed later this year. So that's why we've now got to relook at the staffing we've got and look at our activity data. And there might be a little bit of a review to see where we put the staffing. But we've been using a safer staffing tool as well for each neighbourhood to make sure that it's even.
Thanks, Sally, and helpful in the current environment, as tough as it's been for other people on the call, that you've had to do it within existing funding envelopes. So that is quite an achievement. I'm conscious of time, and we will just wrap up in a minute. But before we do, I wondered if I could ask both Nick and Sally and Kate just a question for those who are just starting out on this journey. What one thing would you do differently, knowing what you know now? What kind of, I know you've done a little, you've given some advice. Is there kind of a key learning that you would give? So I'm going to ask Kate and Sally and Nick for just one final pearl of wisdom. No pressure.
One of the questions that I get asked a lot, so provider collaboratives, I think, often get thought about being acute provider collaboratives. So I often get the kind of like, well, where's mental health, where's community in the thing? I think one of the things I would always go back and start with is kind of like, who's in the room? Like, have we got everybody who's supposed, you know, like, is everybody in the room? But actually being really open about that with everybody, about like, we have got mental health consultants involved. It's not just physical. We have got community providers involved. We have got AHP leads. We have got CNS leads. And I think I probably spend a lot more time going back over that ground than I think I need to, and just kind of like that comms, that engagement piece, that definitely I would go back and do more of that from the get-go. That would probably be my one big thing.
Really, really helpful piece of advice. And Nick, one thing from you?
Language.
Yeah.
The number of times that we have tripped up because we say the same thing but interpret it differently, I think is, I can't count the number of times that I've had to kind of go back over conversations, or we've had to kind of pull people back from the brink, or because of what in one part of the system, one part of the environment is sort of a very innocent, you know, phrase, term, is kind of to someone else a kind of a red rag to a bull. So don't underestimate the importance of language. Don't assume that you are talking the same language. And I think I'm like certainly that experience across the INTs, but you know, likewise within the provider collaborative as well.
Nick, two great pearls of wisdom there. And also just to really say thank you so much, Kate, Sally and Nick, for sharing all that you've done. It's truly inspirational. Just some of the kind of headlines as a reminder that we will send those slide packs to you in your follow-up event email, and we will write them up and think about different ways we can share this content. And I'm just noting Sarah in the chat, keen to kind of just on some of the details here, share that safer staffing model. So Sally, I'm sure that you will pick up on that one. I think there's been some really amazing kind of reminders here on some of the benefits to be realised. Those messages from you, Kate, about using data to know your population, being really tenacious in solving those system barriers. I have to say my head kind of spins at that 32 data sharing agreements, but you're showing it can be done. Keeping that focus on, as you said, Sally, eyes on the prize, your kind of North Star around outcomes, and not forgetting some of the how much an important change management piece this is, and having the kind of dedicated project management if you can. And Nick, I think on your eating the elephant, really powerful on how you've built the case for change, thinking about that two-stage process. Loved your focus on activating staff in your logic model and what that would unlock in terms of, and in the end, activating communities. And just going back to the kind of focus of the session today, you're beginning to work it through, Nick, about that role of the provider collabs here is at the engine room behind all of this, the opportunity for them to really drive this work, and what's happening then at Place in terms of setting that kind of focus and the commissioning role, and then the way that INTs can play such a powerful role in driving change for patients and service users and local communities. So absolutely fantastic set of learning there. So thank you so much to speakers. Thanks to all of you for joining the call today when I know everyone is so busy. If you could please complete the evaluation form, it only takes 2 minutes. If you haven't got 2 minutes and you've got 30 seconds, please pop in the chat any thoughts about what we could do to support your work on this agenda. From board level, there's working below board level. We're really keen to do all that we can within NHS providers. So any comments in the chat would be really appreciated, and do keep an eye out for future peer learning sessions as part of our provider collaboration programme. Bobby and Katie are on the call. Perhaps they can pop their email in the chat, so do reach out to them if you have other thoughts after today on things that you particularly like us to focus on in this peer learning programme, on the role of provider collabs, also specifically on developing INTs. So I'll let you all leave on to your next meeting, but thank you so much
Thank
today
you.
for joining us, and thanks again to the speakers.